I would like to thank the PCP Convention Organizing Committee for inviting me to deliver a presentation on setting up a virtual training program. I have no conflicts of interest for this presentation. I've structured this presentation around the 6 steps in transitioning a course to remote learning, which I have used as a professor in the University of the Philippines. I believe it will also apply to internal medicine residency and specialty fellowship programs. I also did a PubMed search of pandemic adaptations to postgraduate medical education, and I will discuss these journal articles I found to demonstrate these 6 steps. So the 6 steps are: step one, analyze your learners and the learning context. Step two, organize the course content. Step three, select and curate the learning resources. Step four, design the learning activities. Step five, plan the assessments. And step six, write the training guide. So let's start with step one, analyze your learners and the learning context. Our learners are either internal medicine residents or fellows in training. How will the virtual training be incorporated into their busy schedule of duties and rotations? What is motivating our learners? Are they languishing? Did you read Adam Grant's article in the New York Times? Adam Grant said, languishing is a sense of stagnation and emptiness. It feels as if you're muddling through your days, looking at your life through a foggy windshield. And it might be the dominant emotion of 2021. And that's both for the teachers and the learners. What do my learners already know? Did we completely lose the opportunities to learn in 2020? So where do we start now for our virtual learning? Do learners have the necessary technology skills? My millennial students have told me not to assume. So do the learners have the requisite gadgets? Do they have online access? Now more than ever, we don't want anyone to be left behind. And so I quote McCarthy et al., who said, support systems for postgraduate medical learners will need to expand their scope to acknowledge the additional stress related to COVID-19 in the context of an already challenging training. Step two, organize the content of the training program, and corollary to that, determine the time on task. And you can navigate to this online resource. I have the URL here on how to determine the time on task. So one way to organize content is using a horizontal template like this one, where you have a list of the topics, its target learning outcomes, the learning resources, and the learning activities. Now, Phillips et al. Suggests that given the pandemic situation, ensure that there is an increased focus on training in clinical problem solving and critical thinking. So, because our internal medicine residents and fellows in training have other duties and responsibilities, we need to be cognizant of cognitive load and the time on task. What is time on task? This refers to the total learning time spent on doing a variety of things like reading the course material, watching the videos, participation in online discussions, doing the research, writing papers or other assignments, and completing projects we assign. So I suppose those in my audience today are internal medicine residency or fellowship coordinators, and you will be running these virtual training programs. So yes, we also have to think about your instructional time. What comprises this instructional time? Well, designing and training and creating the training materials, posting new information after the training goes live because you need to have an update, or checking in on student interactions, participation and questions, giving feedback on assignments, and even training management which might include even mundane tasks as answering queries for lost passwords to the learning management system, running after trainees with no online submissions or activities. Step 3, select and curate the learning resources. We're in the middle of a pandemic, so let's not reinvent the wheel. Look for open education resources online whenever possible and use those. So here I have some beads, and it's up to you to make a necklace, and only you can do that because you will know the context of your learners. Creating a learning resource from scratch should be the last resort. So in the past year, we have had so many webinars. And so may I suggest that the Philippine College of Physicians perhaps develop a library of high quality webinars. We could organize it by PCP chapters or maybe by PCP training hospitals. If the webinars are long, we can actually repurpose them. We can segment the webinars into shorter videos and follow the TED Ed lesson format. So here I have a screenshot of the TED Ed website, and it is free for educators to sign up for TED Ed lessons. So let's begin. As you can see here, is the introduction to the lesson. And then watch is where you actually view the video itself, and then the think section contains multiple choice questions or short answer questions. The dig deeper is where we can add optional resources for further reading. The discuss section contains questions where the community can answer, similar to an online forum. Mo et al. Have described a collaborative virtual institutional didactic program for oral and maxillofacial surgery. But I believe that the PCP can have a similar initiative. So this was a 20-week e-learning course organized in blocks with live sessions every 3 weeks, consisting of a 45-minute lecture followed by a discussion between faculty experts on the topic and a Q&A with the attendees. The training institutions collaborated for the content and made it available to all. What I liked in this e-learning collaboration was that the individual programs were free to determine the degree to which the program is relied on for resident training and the attendance requirements of the trainees. I could imagine, for example, if you have a learning institution without an endocrinologist, perhaps you can say, well, let's do weeks 10 to 12 if those are the weeks that are for the endocrinology block, for example. Step 4, designing the learning activities. Should you be using a learning management system like Moodle or uploading resources to Google Classroom, please do not use these tools as a glorified Google Drive. We need to encourage active learning and discourse with our learners. Now, a learning management system will allow you to have discussion forums and online quizzes. You can use Google Docs for collaborative writing and annotation. E-portfolios can reside on blogs, and we can still have online reporting via Zoom or Google Meet. Now, let's take a look at some of the journal publications I found. Gizondo et al. Used a flipped classroom method where the learners take a pretest and then they watch 3 10-minute video modules. They take a post-test and then they go into 2 20-minute case-based discussions with a facilitator. So that's one way of doing it. Now here, this one is Kovner et al. They introduced a very interesting gamified version of the challenging case conference. This involves two teams of residents. So the first team submits a real case that challenged their clinical reasoning abilities. Then, via a live Zoom conference, a second team of residents who do not know about that case will play through a simulated tabletop version. So the case actually unfolds in real time, and the playing team can ask for results of diagnostics and can order interventions. After the case is finished, the two teams discuss the various challenges of the case and engage with the virtual audience. So where does the gamification come in? Well, as the team members ask for diagnostic studies, the facilitator puts the hyperlink in the Zoom chat of the Dropbox file that corresponds to that request. So this way, not only is the participating team able to see it, but also the audience. So as the case unfolds, the audience can follow also what's happening. Now, for interventions, they are asked to roll a dice to see what happens. So for example, if they roll a 10 to 12, that means that if they ask for intubation, the intervention is successful and the patient gets intubated. If they roll a 7 to 9, Success comes with an unexpected consequences. So for example, IV access is obtained, but only with a small bore needle. If they roll a 1 to 6, the action is deemed unsuccessful and the patient, for example, becomes hypotensive. So that actually introduces a twist in how the case unfolds. Now, another example of learning activity comes from Almazork et al. So they used MS Teams, Microsoft Teams, to post an image of the week challenge, and it includes a live poll before the scheduled Friday morning conference. So as you can see here, they have the image of the week, and then they have to check here what is the most likely diagnosis. And they found that doing this, because they reveal the answer at the actual conference, it serves to generate interest. And then there's the Rapid Fire Journal Club from Chu. So because it was pandemic and people were very busy, they wanted to cover more journal articles to allow more residents to present in 1 hour and to have more time for Q&A. They introduced the rapid fire format, where the journal article is discussed by the resident in 5 minutes only. And the following three questions have to be answered within 5 minutes. So the questions were: what were the main findings of the article? Two, what were the main strengths and weaknesses of the article? And number three, why did they choose this particular article? Now, step 5 is to plan the assessments. How will we evaluate that learning has actually taken place, that the target learning outcomes have been met? Let's take a look again at the pandemic literature. So Phillips et al. Wrote about considering having dedicated virtual training clinics where the trainers can vet the patients to be seen by the trainees. They suggest the need for a new assessment tool, as the nature of trainer supervision in a virtual environment will of course be different. So the trainers will also need to organize pre and post clinic debriefing and discussion. I know that this will entail more work for residency and fellowship coordinators, but I really think that to better evaluate our trainees, we will really need to observe them at their clinical encounters, even from a distance, in a virtual environment. And so I was happy to find this journal article by Kostich et al., where they shared a direct observation telemedicine skills checklist. And it includes the following: ensures environmental privacy for both the patient and provider, demonstrates the ability to join the visit on a video visit platform, if needed, assists patient in joining visit on video visit platform and can troubleshoot technical difficulties, creates note with correct verbiage needed for billing purposes, uses appropriate professional telemedicine communication techniques, obtains appropriate history for visit needs, conducts physical exam as appropriate and able, engaging the patient in the exam, notes relevant observations from the video of the environment, provides family guidance on adjustments needed to video to improve the visit, appropriate diagnosis and triaging based on patient information, identifies when and how to escalate care, offers clear explanation of treatment plan and next steps to family, and allows the patient to disconnect first. So I put some of them in bold letters because they particularly struck me as something I wouldn't normally teach a resident or fellow, but that which we need to observe now and assess. And I also used it to look at my own telemedicine skills. So things like, can you troubleshoot if something happens? Like, I've had patients lose connection, or I can see them but I can't hear them. I really do not ask the patients to pan the video, but apparently you might need to do that so that you can have relevant observations of their environment at home. Uh, I have had to, yes, ask them to adjust the angle of the camera sometimes so we can have a better video visit. And I don't know about you. Do you allow the patient to disconnect first? So these are things that we now have to teach and learn ourselves for our trainees. Now, Khan et al. Describe a mock OSCE using Zoom with four stations. So, two had standardized patients and two were for technical skills. And it had one main meeting room to assemble at the beginning, a waiting room for the residents in between the stations, and then four other Zoom breakout rooms. Now, each station was 10 minutes long only, and 2 minutes was given to read the case stem and the task to be done. And there was 8 minutes for the encounter for the standardized patients and for the videos that were shown. So by this time, I'm sure many of us have already conducted virtual OSCEs or exams via Zoom. And I was really wondering when I saw this paper about the very short time limits. In this case, only 10 minutes per station. So next, let me go through a few slides that suggest what I would call out of the box thinking. McCarthy et al., for example, say that although formal assessment does drive learning, as competency based assessment progresses and becomes more robust, some hope that examinations will no longer be required in their current form. And so I was thinking no more exams, no more multiple choice questions that fall short of truly evaluating skills and attitude. Well, that's a thought, right? Now, this one is interesting. How about body cameras, which I've only seen, for example, on policemen? So, McCarthy et al. Said that in the future, teaching emergency interventions may require physicians to embrace technologies with competency assessments based on body camera video recordings, for example. So, can you imagine our trainees are wearing body cameras in the wards, and the residency or fellowship coordinator reviews the footage to evaluate certain learning outcomes like procedural skills. For example, if they suddenly have to intubate someone or perform some other procedure while they're doing their work. Strong et al. Also asked us to consider this. Competency based, time variable training can be explored to enable programs to shorten time bound rotations without lowering performance expectations. So we need to be more efficient in actually documenting the outcomes for our trainees because if we do so, if we can structure them to go into rotations, not necessarily time bound but when they are able to already demonstrate proficiency in the outcomes, then they can move on to the next rotation. So I know that that's going to be hard because we all have our schedules, but that's something that we might need to think about because of the different schedules that the pandemic has put us through, where the residents have to be, for example, quarantined or need to have time off out of the COVID ward and into the non COVID ward, etc. So it also means we have to figure out how to properly and easily document our residents' learning encounters. So we can say, for example, oh, you've already fulfilled the learning outcomes for the endocrinology rotation, so we can move on to the next rotation. And so I find these guiding principles from Phillips et al. To be valuable. Number one, facilitate trainee progression whenever possible, especially during this time of the pandemic when we truly want everyone to finish and graduate on time. So we need to focus on those trainees who are at critical progression points in their training. Number two, we need to carry out assessments with fewer people. And that's why I showed you that mock OSCE where they only needed four people and they could evaluate four residents simultaneously. Because as we know, we are short on staff. And then three, to reduce the burden of evidence collection for training, we need to recognize valid alternative experiences gained during the pandemic. And so I'm glad that the PCP asked me to talk about virtual training programs because I suppose that might be an alternative experience that we can also evaluate. So the last step is step six. And step six is to write the training guide. So, such a training guide would include a description of your virtual training program. It should enumerate the learning outcomes, contain an outline of the topics, and the mode of delivery should be stated, whether it's going to be by Google Classroom, a learning management system like Moodle, or if you're going to use video conferencing like Zoom or Google Meet. The training materials, or at least the links to it, should be included. And the schedule is important so we can set expectations for our trainees and to give guideposts to learners as to their progress. So requirements must be clearly stated as well. So these are actually elements of what the University of the Philippines asked the faculty to make last year, and we call them course packs. So course packs are designed to guide students in remote learning. It's as if you are there with the student, even as he studies alone. And so to summarize, here are again the 6 steps in setting up a virtual training program. Analyze your learners and learning contexts, organize the course content, select and curate the learning resources, design the learning activities, plan the assessments, and write the training guide. Thank you.